Good morning and welcome to Beyond Telehealth and Telemedicine is Medicine. I'm Dr. Lisa Finkelstein, and this morning we're going to be talking to Dr. Joey Bledsoe, who's an emergency physician. But I'm going to have Dr. Bledsoe introduce himself. And Joey, if you could tell us where you practice, what EHR you use, and what telemedicine platform that you use.
Yeah, Lisa, thanks for having me this morning. I very much appreciate it. It's great talking with you. I'm Joseph Bledsoe. I practice or have practiced for the last 10 years with Utah Emergency Physicians, which is a large independent emergency physician group in Salt Lake County, throughout the Wasatch Front in Utah. We care for about 350,000 lives annually, so a pretty big group with a pretty big footprint in Utah. On the side, I also have a separate contract with Intermountain, and I'm the research director for emergency medicine and co-director of research for trauma services for Intermountain, and I've been doing that for about 9 years now. So as part of that work, I do a lot with decision support and implementation of care process models, which for Intermountain care process models are essentially best practice implementation. And so I've done a lot of work in both research, but also in quality. So that's about it in a nutshell.
Well, that sounds not very exciting. No, I'm just kidding. but that has, I'm sure, led you, being very research oriented and policy oriented, to being interested in telehealth. And you and I met last year when we were both involved in a grant for telehealth, a HRSA federal grant, and we were introduced to each other because you are another true telemedicine champion. The previous interviews, we've talked about how physicians have had to jump in. They were forced into using telehealth. We're going to go leapfrog over that and go right into your exciting program that you've started and implemented with COVID patients. So enlighten us about what you've been doing over the past several months.
Yeah, so COVID has obviously introduced a lot of challenges in the care of patients in the emergency department, but throughout all venues of care, really. What's come to the forefront for us at Intermountain is telehealth solutions to help care for these patients. And so as part of that, I have helped with our remote patient monitoring team to develop a ED-based remote patient monitoring program. And essentially how it works is we take patients who come to the emergency department on their own, seeking care. We do some risk assessment on them using best evidence that we have, which frankly isn't a whole lot. With all things COVID, it seems we're building the ship as we're sailing. But so we use some risk stratification to help decide those patients that may be safe to go home. And so once we've identified patients that are safe to go home, but that are at higher risk of either having decompensation, requiring return visit to the emergency department, or return and admission to the hospital, we're deploying a remote patient monitoring kit. And that kit is, we have co-developed it with Harmonize. I'm realizing now that I failed to tell you which EHR we use and which telehealth platform, but we're a Cerner program, or we're a Cerner healthcare system. We have a customized variant of Cerner called iCentra that we use. And we have our own Connect Care platform, but also you utilize Harmonize for a lot of our Intermountain at Home and remote patient monitoring programs. And so for this ED program, we worked with Harmonize to develop what we call a COVID mini kit. And because the primary concern for most of these COVID patients isn't low blood pressure or weight changes, it's pulse oximetry. So it's oxygen levels. And so we've developed this kit that's essentially just a pulse oximeter. It's a Bluetooth-enabled pulse oximeter that connects to a Harmonize app on their phone. And then that app enables the patient's vital signs, oxygen levels, and heart rate to be transmitted back to a monitoring center. We have 24/7 monitoring techs, and now have hired nurses as well who are working in that monitoring center, who are keeping eyes on every patient who's enrolled in the program 24/7. And if there are any abnormal vitals, and we came up with a algorithm for identifying what's abnormal and how to assess those patients, they will contact the patient. And the reality is about 80% of the time, the abnormal alert turns out to be a false positive alert. So it's, the patient didn't have the pulse oximeter on their finger right, or we've even seen them putting their pulse oximeter on their 90-year-old mom or grandma, or so it turns out that a lot of the alerts are false positives, but that's okay, because we're able to provide that layer of safety for patients, and we certainly are accepting of a false positive alert rate in order to ensure that we're capturing those true positive alerts. And then for those true positives, patients are mostly referred back to the emergency department, but we also have programs in place to get them referred back to a Connect Care provider, which is our other telehealth platform. So they can have a virtual video visit with the patient in order to assess them, or we can get them referred back to their primary care provider if it's a non-urgent or emergent type alert.
So I have a lot of questions about that. So, I mean, it's a great idea and it's working, but how did you get the team together? How did you get that, the people that man the dashboard and the nurses? Are these all a part of Intermountain, that work at Intermountain?
They are, yeah. So I can't take credit for any of that. That was all Carrie Polikanis, and who's the senior medical director for.
He's awesome.
She's amazing. So she had built that infrastructure already. And I came in and really just helped to figure out the deployment of the process in the emergency departments. So yeah, she had already built the monitoring center.
She's a nurse practitioner.
Yeah,
Yeah.
and she's a nurse practitioner with experience working in an emergency department. So it's actually been really great working with her because she has that perspective of somebody who knows what the workflows are in the ED. And so she's really been a great partner to develop this ED program.
So when a patient comes in and they don't meet the criteria for hospital admission, but they're sick enough and worrisome enough, then you or whoever has to train the patient to plant the seed to say, okay, this is how this works. How is that process, and what's the patient's response to how this program has been working?
The process, so we develop some educational handouts that we give to the patient, but primarily the education lies on the ED nurse and physician. And it's to be frank, the Harmonize platform is really pretty simple for patients, and so the education is also simple. And so I have many hats and do a lot of administrative work, but I also work about 7 or 8 shifts a month in the emergency department. And in fact, at Intermountain Medical Center, which is our flagship hospital within the 22 hospital Intermountain system, where that's our referral hospital. We developed an 18-bed COVID surge zone that's specifically for patients who are either at risk for having COVID or have COVID. and greater than 50% of my shifts are in that COVID zone. And so I see these patients a lot in practice. And the reality is that I will go in and educate a patient on how to use the Harmonize platform. And it rarely takes more than about 5 minutes.
It's pretty simple. It's pretty simple. I've
Yeah.
tested their pulse ox, the Bluetooth. It just like it just works.
Yeah.
Yeah, it's great. How about the providers? You and I have spoken about the barriers of getting very traditionally trained physicians to make that leap to using technology to monitor patients. What was, how did that work?
So for this patient population, it just makes sense. And so I think a lot of providers were accepting of it because we saw what happened in New York and we saw what happened in Seattle, and their healthcare systems quickly got overwhelmed. And we knew we weren't going to be able to admit everybody who was at risk. And so having a way to monitor people in their own homes and provide a safety mechanism that would trigger them to come back to the emergency department if they were declining just made clinical sense. So from that standpoint, it was easy to motivate the providers to use it. That being said, having done lots of implementation projects in the past, I knew that we had to make it very easy for providers to use this. Otherwise, the barriers start coming up all over the place. And so a lot of the work that we did early on in developing this program was really just building the deployment of this process into the clinical workflow for the emergency physicians to the point where it's a click of a button and they can order the RPM device. It automatically fires the form that needs to be filled out by the nurse to make sure that the device number is captured and sent to the monitoring center. And so a lot of the work to get providers, both physicians and nurses, to use this was that back end stuff in the computer that makes the workflow easy. So I think the key to our success was making the workflow easy for both the physicians and nurses.
And you were able to do this and integrate it with Cerner?
Correct. Yep.
Yeah. And the platform the video platform that you use, the Connect, what is it called? Connect Pro? Connect Care?
Connect Care is the direct to patient platform that we have.
And is that embedded in Cerner, or is that a separate standalone platform?
It is integrated into Cerner, but it's its own platform. So
okay.
Yes, it's not embedded into Cerner in that it's not completely supported by Cerner, but we've worked it so that way it can be integrated into Cerner.
Okay. Yeah, these are barriers that most people don't know about or think about.
Yeah.
And then the another metric for utilizing telehealth is, does it reduce cost to the healthcare system? Does it save money? Does it save time? Does it save travel? Are you guys collecting data on that? Do you know that that's true?
We are collecting data on it. That being said, I don't have specific numbers that I can give you.
Yeah,
other than we started tracking our ED recidivism rate at the beginning of the pandemic. And so our 14-day return to the emergency department rate was about 25%. Meaning of those patients that came into the emergency department and had a COVID test, so suspicious for COVID or had a positive COVID test, 25% of them were coming back to the emergency department in 14 days. And then after we implemented this program, it dropped to 17%. And so we know that the return to the emergency department rate dropped 8% over about a month period of time after implementing this program. And an ED visit on average, I it is very expensive, but on average, it's about $5,000 just to walk through an emergency department door,
Right.
and have anything done. And so I think in many, and actually our admit to hospital rate. So of those that came back, we were admitting about 30% of those that came back to the emergency department, which means 70% were coming back to the emergency department for repeat visits and still going back home again.
Right.
And so I think our primary cost savings is in those patients who were worried enough to come back to the emergency department but still didn't need admission to the hospital. And with this program, we were able to help identify those patients and provide some resource to them in the form of monitoring, which gives them reassurance. But also, as part of the program, there's 3 questions that are asked. And if the patient has concerns, as part of those 3 questions, the monitoring techs will call them to assess what their concerns are. And early in the program, the person who was responding to those patients who had concerns about their symptoms was actually Carrie Polikanis, who's a nurse practitioner and has ED experience. And so I think we were able to avoid a lot of these return ED visits and avoid them safely because we had a resource and a way to reassure those patients who were worried but still weren't declining. So
Right. So the satisfaction rate of the patients and the families was very high, or is very high, correct?
yeah, very high. Yeah, I I have only heard of we've enrolled over 2,000 patients in the program, and have only heard one complaint, and that was a patient who triggered a vital sign alert. It was confirmed to be a true vital sign alert, and so he was told to come back to the emergency department, and then was sent home from the ED, and so was upset that he wasn't admitted, or was
Right.
upset that he was told to come back to the ED to get checked out, but then wasn't admitted for his problem. So I don't know if that was a complaint of the program as much as it was just dissatisfaction with the events that occurred after he
Right,
returned.
right. Sometimes it's hard to please everybody.
Yep.
Yeah, it's impossible.
Yep.
After COVID is in the back window, so to speak, the rear view window, which who knows when that will be. Do you think in the future that you're going to use this type of monitoring program for other chronic, or, we say chronic, but patients that have chronic disease that come to your emergency room for acute episodes for many, many reasons? Would you continue to use this type of program?
Yeah, I think absolutely. So let me tell you about the phase 2 of this program that we deployed at Intermountain, and I think that transitions into how I think we can use it into the future. But we were monitoring patients and doing that very successfully with a reduction in ED visits. And then we started to get bigger COVID surges throughout Utah, and our hospital capacity started to go up. And we hit over 100% hospital and ICU capacity throughout the Intermountain system. We had been deploying load leveling, so patients that come to the emergency department that needed to be admitted weren't being admitted to the hospital they were coming to. They were being admitted to the hospital that had capacity to admit patients. And so we had already deployed that in order to help avoid overwhelming our particularly bigger hospitals. So in order to help combat that capacity issue, we subsequently deployed a home oxygen program. So now we were taking patients who were mildly hypoxic with exertion, who were previously getting admitted to the hospital, and developed a way to send them home on home oxygen with the same RPM device. And at least the last time I looked at the data, we had saved close to about 1,500 hospital days by safely keeping patients in their home on home oxygen, which helped to keep us from overwhelming our healthcare system and our hospitals, and allowing the sickest patients to have resources available to them.
And was
And
this
so,
utilizing people in the field for home health?
Yeah, Intermountain has an integrated home health arm, and so yeah, we utilize the integrated home health company with Intermountain, and they were able to provide home oxygen for these patients. And again, we built it into the workflow, so it was really easy for the ED and nursing providers to deploy this from the emergency department. And so in that process, we were taking patients who were previously admitted, and we've been safely caring for them at home using remote monitoring plus oxygen in this case. But I think that can easily transition into many other disease states after COVID. Um, I presented this at one of our system-wide medical leadership huddles, and a pediatrician from Primary Children's gave me a call afterwards and said, hey, in the wintertime, we typically have about 40% of our hospital volume at Primary Children's as patients with bronchiolitis, and most of them are just being monitored for drops in oxygen. And so he said, how can we partner with you in developing a bronchiolitis program? So that way we can keep these kids out of the hospital, keep them at home, but still safely monitor them in the outpatient setting. And so I think that's a perfect example of where this may be deployed after COVID, once the dust is settled there, and allow us to safely keep patients in their home.
I think as physicians see, different needs, that is a great example. When I was first trying to get physicians to use telemedicine a couple years ago, I would say, don't listen to my ideas. What are your ideas? Because
Right.
your needs are different, right? A pediatrician's need is different than a general surgeon's need, but they brainstorm and they come up with this idea. Okay, wow, this could really help this situation. And then it just mushrooms into more and more ideas.
Right. Yeah.
Yeah.
I mean, I think that the best or the projects that have the most potential for improvement in healthcare come from the bottom up, but also have to be supported from the top down. And so you're exactly right. You have to go out to the people who are providing the care on the front lines and say, how can we support you? But
Right.
then you have to provide that support from the top down as well.
Right. Well, I had a bunch of questions, but because we're at 22 minutes. Let's go to the future. I mean, we've talked about the future, but as a telemedicine champion, and are familiar with a lot of the hurdles and the barriers, and we're in this new age of innovation. If you could think of how you see telemedicine moving ahead, I know you're an ER physician, so you think in that
Yeah.
way. Tell me what the future holds for telemedicine.
I think there's a ton of potential for telemedicine to improve care. In my mind, the areas that have the most potential impact are one, providing transitions of care. So transitions, and there's lots of literature on this, are high risk events for patients. So transitioning from the outpatient or clinic setting to the ED, and ED to inpatient, inpatient to back home to the outpatient setting. There's often a delay in care between when a patient's discharged from the hospital and when they can get back in to see their primary care provider. And I see a telemedicine solution to help make that transition more smooth but also more safe for patients. It also, I think, could, from a quality impact, or from a quality standpoint, have an impact on things like CMS measures and hospital readmission rates that every hospital obviously has focus on, as it impacts the bottom line, as well as potentially causing patient harms. So I think transitions of care are a huge area where there could be impact, and then providing care and resources or expertise to rural communities. I think there's a huge potential for impact there. And you and I have talked about the project that you're working on, and I'm excited about it because I think there's a lot of potential improvements that could be made in the care delivered to the rural communities of Wyoming, but you could extend that even further to, lots of rural communities throughout our country.
Right, because the statistics that I read is that there's at least 60 million people that live in rural communities. That's a lot of
Yeah.
people who don't
Yep.
get great care and don't have access to specialists or primary care or emergency rooms.
Right. Yep.
We could go on and on. You mentioned CMS, and so one of the barriers is getting paid. And that has always been a sticking point for our physicians and administrators is, Lisa, are we getting paid? How are we getting paid? How are we getting paid? I'm always hesitant to say this, but I now say it often, that if it wasn't for the pandemic, we would be still trying to push that rock up Mount Moran,
Yeah.
and, kind of squished 10 years into 10 minutes. And CMS just as we say, it was unprecedented, the changes that they made in the payment models. But they're talking about, they only have 9 codes that are now permanent changes. And so it's like this much, and we need an act of
Yeah.
Congress to change the laws.
Yeah.
And so all these ideas are great and wonderful, but, the doctors say, if I'm not getting paid, I'm not doing it. What's your thoughts on that?
Yeah. Ultimately, medicine, we as physicians take the Hippocratic Oath to do no harm to patients. And I think we all have motivation to do what's best for patients. But in the end, it's a business. And healthcare systems exist because they get paid to provide that care, and physicians do their jobs because they get paid to do their jobs. And so you have to figure out a way to get payment for these services provided. And I think ultimately it's going to be on those of us that are doing work in telemedicine to prove the benefit and the cost effectiveness, and that telemedicine can provide value-based care for patients. More and more, we have been for a decade now. I've been hearing value-based care and
Right.
accountable care organization and terms like that being thrown around for a decade or more. And in the end, though, I think that that's where we've got to get as a society and as a nation if we want to improve the healthcare for all of our patients. And so I think it's on us to prove that this provides value and is cost-effective medicine.
I say it's not just on us, right? Because we have a lot on our plates. But I, in the beginning, went to the patients, and I would say, if you guys love this, then please, and I would hand them a template, a letter to send them to their insurance companies, their private payers, and say, you have Parkinson's disease, and if it's important for you to be able to get speech therapy from your home so you don't have to schlep in the office 5 days a week, then you need to tell them. You need to write to your Congress people and plead your case and tell your story. So I believe in also empowering the patients to tell them how much they love what you're doing.
Yeah, absolutely. I think that's fantastic. So it has to be multifactorial.
Right.
Yeah.
Hold on. Let me see if this is okay. That's just a atta girl comment. Okay. All right. Well, Dr. Bledsoe, I really appreciate you enlightening us about what's happening in Intermountain. I love Intermountain. The people that work on the telehealth teams and are in that boring background work, you guys have some strong, awesome people. It's been a pleasure to work with your hospital system and you as well. So thank you for joining. I appreciate it.
Yeah. Thanks, Lisa. It was great talking with you this morning.
All right. See ya.
Bye.